Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh and good morning. I would like to welcome all of you to today's breakfast at UMHealth in conjunction with the celebration of World Antibiotic Awareness Week and Hand Hygiene Campaign 2021 with the theme of Spread Awareness, Stop Resistance and Second Save Life. Thank you for the visibility unit of the Faculty of Medicine for having us today. First of all, I would like to say sorry because of the earlier technical issues. Good morning and welcome everyone to today's forum. Ladies and gentlemen, the rapid emergence of resistant bacteria is occurring worldwide, endangering the efficacy of antibiotics, which have transformed medicine that saved millions of lives. In April 2014, WHO has stated, in which I quote, "This serious threat is no longer a prediction for the futures. It is happening right now in every part of the world that has potential that affect anyone of any age in any country. Antibiotic resistant, when bacteria change, so antibiotic is no longer work in people who need them to treat infection, is now a major threat to public health. Many decades after the first patient were treated with antibiotics, bacterial infection has again become a threat. We enter post-antibiotic era now. Several fields of modern medicine, such as chemotherapy for cancer treatment, organ transplantation, surgeries, intensive care, and other activity could not be performed without effective antibiotic. In fact, infection caused by multi-drug resistant organisms are among the main factors influencing morbidity and mortality in patients undergoing these procedures. The antibiotic resistant crisis has been attributed to overuse and misuse of these medications, as well as lack of new development from pharmaceutical industry. Therefore, to discuss further on these issues today, in order to increase awareness to stop resistance, with me, there's 4 distinguished panelists to share their knowledge and experience. First, a special guest from USA, Prof. Sasheela, who's currently on her sabbatical leave, doing attachment in Johns Hopkins. Hi, good evening, Prof.
Hi, and good evening and good morning to you, Sazali. So nice to see all of you.
Let me know if I can help. Next to me is Puan Hasimah, our Chief Nursing Officer of UMHealth. Assalamualaikum, Puan.
Waalaikumsalam. Hi, everyone.
Okay, our third panelist, some may regard her as their foes, as she's always nagging us about the use of antibiotics. But they're actually our close friend to ensure patient safety. I'm introducing Ms. Lim Ka Yin, Pharmacist of UMHealth. Hi, good morning, Ka Yin.
Hello, good morning.
Okay, and last but not least, my partner in crime in infection control, Dr. Zuhairah Mohamad Razali. Zuhairah, COVID still ongoing, not reducing, but now cholera is coming. Are you ready? Okay, so without further ado, let me start our forum today with the first question I will ask to Prof. Sasheela. Prof, we have this celebration of Antibiotic Awareness Week and also hand hygiene every year. May I get your opinion and takes on the importance or significance of having such celebration? To you, Prof.
Thanks, Sazali. It's a very good question. So, why are we having this celebration? So, as you have just mentioned, and everyone is aware, multi-drug resistant organism is a growing threat not only in our country but globally, and not only multi-drug resistant organism, but also hospital-acquired infection is one of the leading cause of mortality and morbidity in hospitals today, and causing severe risk to our patient and patient safety. Patients come to the hospital to get better, but unfortunately, many of our patients end up going home or staying in the hospital for longer periods of time because of hospital-acquired infection and multi-drug resistant organism. How does a patient get it? Well, there are 2 ways. One is the emergence of multi-drug resistant organism, and that occurs when antibiotics are used overly, inappropriately. We start developing multi-drug resistant organism, which my colleagues will talk about later, more in detail. And the other way is transmission of these resistant organisms, or any organisms for that matter, from one patient to another, is because of poor infection control, such as, if you don't wash your hands properly, and I think Zuhairah will touch on that later. So by these 2 ways, multi-drug resistant organisms and most of hospital-acquired infections are transmitted from patient to patient. And these are actually preventable. More than 60% of hospital-acquired infections and MDROs are preventable. They cause significant mortality and morbidity in our patients, increase less length of stay, and increase economy. So unfortunately, antibiotics are so precious. As you know, since antibiotics first came about, it has saved millions of lives, and it is called the miracle drug. Unfortunately, we are losing the potency of this miracle drug, and they're not effective anymore. And even though they are miracle drugs and they're so precious, unfortunately, both healthcare workers, the prescribers, as well as the public do not treat it preciously. Anyone can prescribe antibiotics. Unlike some medication like chemotherapy, can only be prescribed by an oncologist, or a hematologist. Not everybody can prescribe chemotherapy drug. But antibiotics can be prescribed by everybody because it is thought to be a very simple drug or a safe drug. Nobody knows how much of effect it's having today. In fact, it is known as the slow-growing pandemic because one day we may not have antibiotics and save lives. And the other thing is, in many countries, antibiotics can be bought over the counter by the public. So anyone who feels sick, they straight away buy antibiotics instead of treating their symptoms or going and seeing a doctor to know what is the diagnosis. And because of this, we are losing our antibiotics, and the drug companies are not able to come up with new antibiotics as fast as we are losing our antibiotics. And because of this, WHO has come up with this awareness campaign for both public and healthcare workers, so that we are made aware of the importance of antibiotics and infection control in patient safety and saving lives of patients today, and also conserving these miracle drugs for the future. Thanks, Azali.
So, Prof, just now you said anyone can prescribe antibiotic, and we easily can get antibiotic in clinic. So, what is the need of aware of the antibiotic AMR, and what's the link between antibiotic awareness week and also hand hygiene?
So, WHO and many guidelines, IDSA and international and also our local guidelines have come up with strategies to use antibiotics. Antibiotics are important. It should be used where it's needed. And therefore, the awareness is to educate prescribers as well as public that antibiotics should be used smartly or prudently. That means must be used when it's needed. Must be used in a timely manner, and I think Ka Yin will go more in details into it. So it's to bring awareness that antibiotics does not treat everything. For example, someone who has dengue doesn't need antibiotics, but studies in Malaysia have shown, or our audits have shown, almost 90% of patients who come to us by day 3 or day 4 of dengue have already gotten some sort of antibiotics from a GP, or they have bought an antibiotics on their own and taken it. So this awareness is to inform people that antibiotics, perluka, always think, do we actually need these antibiotics? Is it just a viral infection? And also, that is, as I said, the emergence of antibiotics is because of, emergence of resistance is because of antibiotics. But the propagation from one patient to another, of one person to another, is because of poor infection control. And that is the link. So infection control and antimicrobial stewardship, that is good antibiotic use, has to go hand in hand. And as ID physician, we have seen it for ourselves. Just by being antibiotic stewards, we cannot reduce the rates of hospital-acquired infection and multi-drug resistant organism. We have to work with our infection preventionists, and only then we can bring it down. So I believe both of them have to go hand in hand, the awareness both to public as well as healthcare workers, that to reduce our hospital-acquired infections and MDROs, we need both infection control as well as antibiotic stewardship. They will not work alone together.
Thank you, Prof, for that thoughtful insight and of the importance of antibiotic awareness and also creating awareness among everyone and observing good infection control practice. So now I will move to our next panelist, our pharmacist, Ms. Ka Yin. Ka Yin, So how does reducing antibiotic usage would actually reduce the rate of MDROs or multi-drug resistant organisms? Ka Yin?
Thank you, Dr. Sazali. So now, before I start to answer that question, I would like to talk a bit about how does MDRO emerge. So in our body, we have good bacteria. So when we are sick or when our immune system is down, bad bacteria will come in. So in that case, during that case, antibiotic will be used. So, but we need to remember that antibiotics kills the bad bacteria and also will kill the good bacteria in our body. So this creates an imbalance in our system as there's now less good bacteria to defend our system. So actually MDRO not only stays in one patient, like what Prof. Sasheela says, it can be spread to other vulnerable patients in the ward or clinics through close contact and also poor hand hygiene of healthcare professionals and also ward staff. So vulnerable patients will be less able to withstand this infection from MDRO. And in the ward and also in clinics, when us healthcare professionals, after we attend the patients, if we don't perform hand hygiene or we don't clean ourselves properly before we are together with our family member, it might be passed on to our elderly in the house and also sick family members. So it is important to have the correct diagnosis and also deciding on the narrow spectrum antibiotics with the shortest course for a patient right from the start of the treatment. And reviewing patients daily is very crucial. If all these aspects are being seen and worked on diligently, this will help to reduce the MDRO rate. So sometimes when we see some doctors will say, oh, I give antibiotic just in case patient might have an infection. Currently don't have an infection, but might have an infection later on. So antibiotics are given to just cover, just in case. So this actually might cause more harm than benefit to the patient. So actually one rule does not fit all. Of course, some infection cannot use antibiotic with a very short duration. Some need a longer duration to treat it, or some need broader spectrum of antibiotics to treat it. But many infections can be stopped by de-escalating to a narrow spectrum of antibiotic whenever possible. We need to strike a balance between our patients. We need to strike a balance between saving our patients today and protecting our patients in the future. We need to save our antibiotics. Thank you.
Thank you, Ka Yin. I hope now more people will be aware that we should use antibiotic appropriately to avoid bad sequences if we continue to use them inappropriately. Antibiotic is precious, so we need to use the antibiotic with care. Okay, next, Dr. Zuhairah, as the main MOs in infection controls, right? I'm sure you are able to share with us your experience and also expertise on tackling this antibiotic resistance. Are there any other strategies apart of reducing usage of antibiotic that will help to reduce the rate?
Thank you, Dr. Sazali, for that important question. Even though I just embarked my journey in infection prevention and control, I can see a lot of efforts and great work has been done and a lot more are planned by the team in combating this antimicrobial resistance as well as preventing infections. So many studies have shown that to effectively reduce MDROs, AMS must go hand in hand with good IPC practices. So as Prof. Sasheela mentioned, infection control prevents transmission of organism irrespective of MDRO or sensitive to the patients. If this transmission is not prevented, it will lead them to be colonized or infected with this organism, which they don't have when they come to the hospital. So the IPC usually includes adherence to the proper hand hygiene, compliance to care bundles such as central or peripheral venous catheter insertion, and also maintenance to the bundle to prevent central line associated BSI, bloodstream infection. Also urinary catheter care bundles to reduce catheter associated urinary tract infection, and also ventilator associated pneumonia prevention bundles. So by reducing this HAI, We will also indirectly reduce MDROs automatically. Hand hygiene also important component in all of this bundle. It is the single most effective and least expensive way to reduce nosocomial infection and MDROs. It's very simple. You just press the alcohol-based hand rub and then you rub your hand 20-30 seconds and you already prevented infection. So another important aspect of IPC is also removing devices when it's not needed. Nurses and doctors can work together to remove each other to remove IV lines or CD when it's not needed. Because as you know, the longer the device is in situ, it can lead to device-related infection. Another important aspect is also about environmental and also equipment cleaning and disinfection. It is also important component in preventing MDRO and HAI. Infection Control Department together with facility and also nursing department has been working hand in hand, providing education and training for our cleaning personnel and also reminding healthcare workers regarding the importance of ensuring to clean their equipment after using to prevent transmission of organism from one patient to another through this contaminated environment and equipment. That's all, Dr. Sazali. Thank you.
Okay, thank you, Zuhairah, for such comprehensive explanation on infection control measures. Okay, now let me move to our next panelist, Chief Nursing Officer, Puan Hasimah. Okay, Puan, so what are the role that nurses can play to improve antibiotic prescribing behavior and also practice? And equally important, actually, how can they help to reduce the emergence and spread of MDROs in our hospital? Puan Hasimah.
Thank you very much, Dr. Sazali. Assalamualaikum warahmatullahi wabarakatuh and very good morning to all. Thank you for having me here, and I would like to congratulate the whole organizing committee for having this very, very important event today, and how the nurses can help with antibiotic prescription. So first of all is that nurses need to have a knowledge of antibiotics and the usage of antibiotics, and also they need to have a knowledge of certain organism or MDRO or certain knowledge of microbiology. That's very important in order for us to ensure that the doctors or the physician will prescribe the right antibiotic, the right dosage, the right time and the right duration. And I still remember previously, before our digitalization, that we usually will color our observation chart so that we know how many days the patients were on antibiotic, and also we know how many antibiotics that were on. And most importantly is that we must know the reason why the patients are getting antibiotic. For what reason? The why thing is very important within the nurses. This will reduce the emergence of MDR doctors in terms of durations and also in terms of prescribing this antibiotic. Secondly, we should monitor the adverse event from the antibiotic that has been given and what are the changes in the patient's condition. So whether the patients are getting worse or patients are getting better through the treatment. And from clinical progress from IV to oral. So what are the challenges there? And most importantly is to educate the patients. What are the antibiotics they are on and why the antibiotic was given, and how to reduce the spread of infection is that everyone must do their hand hygiene. And this 5 moments of hand hygiene is very, very important in the clinical area. And one person didn't wash hands, and that's it. There will be a chain of infection. And secondly is the maintenance of bundles. We have VAP bundles, CPC bundles, BSI bundles. And most importantly, when we access the IV line or the CVC or the art line, to scrub the hub is very, very important. To appropriately do the scrub the hub, the duration of scrubbing the hub, and a good practices in documenting that IV access is very important. Not only the IV, but the CVC, the arterial line, and other tubes that's invasive tubes to the patients. And I do see usually forget to label our dilution of solution. So that's also plays an important role of preventing our MDRO, because if we leave all the solution without labeling, so we keep using the common dilution, we can get the MDRO. And also, nurses can help in early detection and appropriate of culture taken from the patients. Other than that is we need to have what so-called management in terms of our nursing care. So all should be standardized precaution and standardized in terms of maintaining of all these bundles. So I think that how we can help in preventing MDRO in terms of the nurses' role. Thank you.
Thank you, Ponshima. Nurses definitely plays very huge roles in fight against the emergence of and spread of MDROs. Not only remind doktor dah cuci tangan belum, or doktor antibiotik kena continue belum, but I think they have much bigger roles, not only reminding everyone. Okay, next. As we all aware that ID and pharmacists, together with the other department in the hospitals, also as well as the management, have been working very hard for the past years to manage the use of antibiotics. So question to Prof. Sasheela, what are some challenges in implementing these strategies, and what we have done to try to overcome these challenges?
Thanks, Razali. So I think our management has been very supportive in all our antimicrobial stewardship and infection control measures, and we have tried to we use the international guidelines, IDSA, WHO, and the national guidelines, and we have come up with our antimicrobial stewardship policies. So to start off with, for antimicrobial stewardship program, we have a multidisciplinary team, which consists of ID physicians, pharmacists, infection preventionists, our medical microbiologists, and even our IT personnel with involvement of PEDS as well. And with this team, we have tried to put in a few stewardship programs. And the first one is surveillance. I think surveillance is very important. If we do not audit our practices, we will not know what are the mistakes that we are doing, or the gaps in our practices. So we have an audit or what we do, a point prevalence survey on antimicrobial prescribing and also on MDRO. So we kind of know the trends of our MDRO rates, our hospital-acquired infection rates, and how it trends with our antibiotic use. So with this, we know our gap in practices, and we are able to feed back to our colleagues. So we try to feed back at our MEC meeting, HIACC meeting, and we also try to feedback in individual departments like surgical departments as well as medical departments, and work with the teams to improve on antimicrobial prescribing. Secondly, we have conjoined rounds with certain departments like critical care unit, our NICU, PICU, we have some infection control programs, orthopedic team. We have this conjoined antimicrobial stewardship rounds, and this is known as the handshake stewardship or handshake intervention. That means we work together with the teams, we shake each other's hand. Of course, in COVID, no shaking hands, we just do this. But it's not handshake because we work together to improve patients. And I think this is one of the most, though it might be time consuming, but I think this is a very effective intervention, because as we work with these individual teams, we can manage the patients better. They can tell us the patient's cause, what are their concerns, and we can work together on getting the right antibiotic for the patient. And also, this is an opportunity for us to teach the junior doctors from other specialties on how to prescribe antibiotics judiciously, make the right diagnosis, take the right culture, give the narrower spectrum pertaining to that diagnosis, and then de-escalation appropriately. At the same time, we are also able to understand the challenges that these prescribers face, and that way we can work together on how we can improve our prescribing practices. Because I believe at the end of the day, every doctor or healthcare worker wants the best for their patient. It's just sometimes it's a lack of knowledge and fear fear. Sometimes we overdo things because of the fear that we might compromise the patient's health, without knowing that actually by doing too much, we might actually be causing more harm. The other thing is what we have initiated is OPET service, which is outpatient antibiotic therapy, and this we work very closely with the nurses who have been very supportive in this. This way we are able to discharge patients earlier with IV antibiotics, and this way we can reduce patients who need long-term antibiotics. This way we not only reduce costs and prevent further hospital-acquired infections if the patient stays longer in the hospital, but we have also found that many of our patients are more satisfied with the OPET services because they don't need to stay in the hospital and they're happy to come. And so far, our patients who have been in OPET service have had good outcomes. The other thing is we have had other stewardship programs with broad spectrum antibiotics such as carbapenem use, which I think Ka Yin will be talking more about. We also have, with our ID and pharmacy team, pediatricians and all departments, we have sat together and we always update our UMMC antibiotic guideline. And with the help of our microbiology colleagues who diligently come up with the antibiogram for us so that we can keep track of the trends of our multi-drug resistant organisms or the trends of our susceptibility pattern of all the organisms, and that will keep us reminding. The other important initiative that we recently came up with is penicillin allergy delabeling. So recent studies have shown that lots of people are falsely labeled as penicillin allergy, and what happens is most of the time these people get people who are labeled as penicillin allergy actually don't get the best antibiotics. They get broader spectrum antibiotics and their outcome is actually poorer. And studies have shown that more than 50% of people are wrongly labeled as penicillin allergy. And so that is something that we have embarked on, apart from other things such as people who have, had a splenectomy done. The ID team goes in to see them. Patients of Staph aureus bacteremia has shown that with ID involvement, the outcome is much better. So these are some of the interventions that we have put in our AMS program. Of course, the challenges in AMS, I think, is not specific to Universiti Hospital, but this is more of a general challenge that I think every AMS program nationally in any hospital, even in our country, and even internationally, now I'm in Johns Hopkins, I can even see the problems here as well. It's always one is fear of de-escalation. You give a broad spectrum antibiotic and then you're so scared to de-escalate because you think, oh, my patient is getting better. But studies have actually shown, and this is also systematic review in the sickest of sicker patients in the hospital, has shown that if you de-escalate your antibiotics to the culture, or if there's no culture and you still de-escalate it, the outcome of the patient is much better than not de-escalating the antibiotics. Number two is the myth of longer is better than shorter. So now more and more studies have shown that certain infections such as simple cystitis, community-acquired pneumonia, and even hospital-acquired pneumonia, actually shorter is better. So that's the new mantra, shorter is better. The third one is, showing that, sorry, what was I going to say? Broader antibiotics does not mean it is better. Okay, everyone thinks carbapenem is the best drug for everything, but that is not true. Carbapenem does not cover enterococcus very well. So, if you are having a gut infection and you're giving carbapenem blindly, you're probably not going to cover all the important organisms. So broader doesn't mean better. More expensive does not mean better. Think about what infection does my patient have, what is the possible organism, and that's what is the antibiotics that should be given. And I think another challenge I think that we face in an Asian country is the hierarchy. It's always like my boss has prescribed this antibiotic, so I can't do anything about it. So I think that is something that we all need to turn away from. Many of us now have gone overseas. We have seen cultures in other countries. And I think we need to learn that just because we are senior doesn't mean we know everything. I think it's important that the learning process is two ways, and medicine never always stays the same. Medicine always changes, and as healthcare workers, we should always be ready to change for the better for our patient safety. Thanks, Sazali. I think that's more or less our challenges and the programs that we have had in our hospital.
Thank you, Prof. I hope now all of us can work together to overcome these challenges. Okay, next question. As mentioned earlier by Prof. Sasheela just now, some of you may aware that the Antimicrobial Stewardship or AMS round, which run by AMS team, consisting of pharmacists and doctors from ID or infection control to assist and guide other departments to use antibiotic more judiciously. So, for example, we have ICU AMS, we have ortho AMS, we have general medicine AMS, and even carbapenem rounds. So, in most of these rounds, pharmacists and also doctors from ID or infection control will sit together with the primary team to discuss and choose what is the best antibiotic and care for the patient. So, Ms. Ka Yin, can you share with us the role of pharmacists in AMS and share with the healthcare workers, especially the doctors, either senior or junior, the hurdles faced by the pharmacists so that we can all work together to smoothen the rollout of the recommendation or suggestion from the AMS team. Ka Yin.
Thank you, Dr. Sazali. So what we do in UMC is that a pharmacist will screen several types of broad-spectrum antibiotics, such as piperacillin, tazobactam, cefepime, meropenem, and many more in our daily work before we supply them to the ward. So other than doses and frequency of the antibiotics, the pharmacist will go through the patient's note to ensure it complies with the local or national antibiotic guidelines, and it does correspond to the diagnosis. So one of the problem that we are facing is that sometimes in the patient's notes, the diagnosis wasn't written as clearly as possible that we can assess it in our setting. So guidelines for empirical treatment is important as it usually targets the most common bacteria for the sick diagnosis using the local antibiogram. That's why writing the diagnosis in the notes is very important, as we could help to cross-check if the antibiotic is suitable for the diagnosis or not. So besides that, we also follow up with the cultures that are taken and discuss with the doctors about narrowing the spectrum of antibiotics whenever possible. So it is important that patients are not continue unnecessarily on broad-spectrum antibiotics. So there are also AMS pharmacists who work with ID physicians to look into the usage of meropenem weekly, reviewing those patients and also make recommendations to manage the infection. So sometimes you'll get calls from us to say, hello, may I know why is the antibiotic being continued beyond the said treatment duration? Or can you tell me more about the patient's infection? Because we don't really see patients in the ward, so we would want to know better the condition to get a more accurate assessment of the appropriateness of antibiotic usage. So another hurdles that we face is that when the culture result is out, antibiotics are not de-escalated timely, or the doctors will say that, oh, okay, patients still look very ill, so we want to continue until patient gets better. So actually, like what Prof. Sasheela says, it might not be the best solution. Sometimes the shorter duration, or when we de-escalate antibiotics, it might do more good to the patient. So this will also, if we use a broad spectrum antibiotics in a prolonged duration, it might lead to MDRO emerging, especially CRE and VRE. Thank you.
Thank you, Ka Yin, for your explanation. I hope that we will encourage more people to engage with AMS so that we can deliver the best for our patient without causing them any harm. Okay, next question. The infection control, the nursing department, together with other departments and full support by the hospital management, has been working very hard for the past years to implement infection control, good infection control practices. So Dr. Zuhairah and Puan Hasimah, can you please mention some of the initiatives and challenges in UMMC in implementing good infection control practice? Maybe we can start with Dr. Zuhairah first.
Thank you, Dr. Sazali. In UMMC, we have implanted various strategies, many of which are required by Ministry of Health. Firstly, we have an active surveillance for multi-drug resistant organism, MDRO. We also have surveillance for hospital-acquired infection, bloodstream infection, BSI, SSI, surgical site infection surveillance for most clean surgeries, and also surveillance for our critical care unit in terms of CLEPSI and also ventilator-associated pneumonia surveillance. On top of that, we also do audits in hand hygiene, CLEPSI, and also SSI prevention body compliance for selected surgeries. We also have education and training for medical students, house officers, newly employed healthcare worker, and also our cleaning staff. With good collaboration with between infection control department and also nursing and various department stakeholders, and importantly with the support from management, I'm happy to say that UMMC has been shortlisted and in the running for the Asia Pacific Society of Infection Control (APSIC) for Hand Hygiene Excellence Award, and we also managed to reduce the SSI. Among the challenges that I think we face is about the culture of following the wrong practice. So some of us find shortcut to make our life easier. Some of it is helping us, but some is actually harmful to ourselves or patients. Taking example is actually an inappropriate PPE usage, such as using double gloving and then doing hand rub on top of the inner glove, which hinders our compliance to hand hygiene. So this lead to cross-contamination and also contributed to the hospital-acquired infection. Another challenges is actually the understanding behind these infection prevention control measures or practices that we implement. The eyes cannot see what the brain doesn't know. So it is important to for us to understand why we are putting the intervention or implement the infection control practices for that practice. I think that's pretty much about it.
Okay, thank you, Zuhairah. For Hasimah, just now Zuhairah had just shared some initiative done by infection control. Maybe now you can share with us what's the initiative lead or co-lead by the nurses in UMMC in combating antimicrobial resistance and challenges faced by you and also your team.
To add on, Dr. Du had mentioned is that we have embarked on the champions in our area. As we know, like Prof. Sasheela said before, that infection controls is everybody business. It's everybody responsibility. So we have champions from the PPK, nurses, and also doctors. And because hand hygiene responsibility starts from even the cleaners. So we have embarked on all the champions, trainings program in terms of all these champions pertaining to infection control. And secondly, we have infection safety rounds. So now the nursing departments have embarked on safety rounds, and also for to let the nurses to speak what are their concerns in terms of patient risk of infection. So we call it a speak up program. So we just started that. And thirdly is that we embark on the standardized practices, such as now we have started on a program on IV insertion bundle. We put a standardized practices, so everyone should follow this procedure, and we have an IV kit maybe in December. So that's the other initiative that we do. And the challenges that we have in nursing is that lack of consistency. So when newcomers datang, then we have problems. So we have lack of consistency. So every sister and every infection control lead nurse in the ward should have audit, and we have to audit to make sure that we are consistent with our practices. And secondly is lack of understanding among the nurses also, and miscommunication. So they do different practices. So we need more training and education, and in terms of like video to guide them so that they are not miscommunicate about the standard practice. And lastly is fatigue. As we know, we have been combating COVID since last year. So there's a fatigue in terms of infection control, but there's a need for us to continuously motivate And I would like to congratulate also the Infection Control Department who have given acknowledgement during their event so that we continue. Even we are fatigued, we have to continue in terms of infection control and continue standard practicing of precaution.
Thank you, Puan. Yes, MR is everyone concerned, and together we should fight this threat. Okay, so there's a lot of new antibiotics coming out. So why we should worry about MDRO's rate if we have a lot of new antibiotics coming out? Kayin, so maybe you can answer this question.
As you all know, there are millions and millions of funds are being poured into research to find the best antibiotic which can treat the very high-end resistant organism. So usually cost would be an inhibiting factor, and often most patients cannot afford it, even for a short course. So let's say, for example, a patient needs 14 days of intravenous antibiotic treatment for this MDR infection. The cost of the treatment of these 14 days might go up to probably 7,000 to 8,000 just for the 2 weeks. So actually, we can only rely on what we have now and guard them preciously because cost is a concern to everyone. Thank you.
Okay, thank you, Kayin. So next question to Prof. Sasheela. What can we do to reduce the rate of MDROs and to increase the compliance of hand hygiene in our hospital or any?
So I think just like all the panelists, I think like to just summarize, I think like what all the panelists have actually mentioned, both for AMS and infection control, I think it's always going to be education, re-educating, awareness, retraining and retraining, because as I said, things keep changing, and the COVID has taught us that things keep changing all the time, isn't it? And then feeding back. And I think one of the things I think in an Asian country we need to learn is how to feedback and how to receive feedbacks as well. I think one of the things is we should work in a non-training sort of situation, and we should always think whatever we do, we are doing it for the best of the patient. It's not a territorial thing to say I'm better than another person. I think every one of us is a hero and a champion to save our patient. And I think if we can accept and say, thank you for the feedback, I will, improve. I think that's the way that we all become heroes. And it's a two-way thing. Even in antibiotic stewardship and infection control, we have made mistakes. Sometimes I go for ID rounds and I may forget to wash my hands, and my nurse reminds me, and I thank you. So we're all human. We make mistakes, but I think the important thing is for us to learn from it and thank a person for telling us if we have done something wrong. Of course, the other things are, I think there's a lot of science behind it. It is not rocket science, whatever we are saying. But I think one of the important things is working together for patient safety. And I think, now worldwide, there's something called CUSP, like a comprehensive unit-based sort of intervention for everything, where for anything to succeed, it has to be multidisciplinary. And as you can see here, the panelists today, we all come from different backgrounds. And only by doing that and I think and I think Matron Hasimah will agree with me. I mean, we have been in this for the longest time together, even as a junior ID person. We all know that management has been very supportive of all our interventions right from the start. And the best thing about our management is they don't take punitive effect, but in fact, we try to encourage. I think even with our campaigns, we try to we give presents to our PPKs, we give presents to our cleaners, and I think that's the way to move forward. To build people's morale and to encourage them to improve. So I think infection control and AMS is not rocket science. In fact, it's more of social science, and I think that's the way we move forward. Working together. Yeah, thank you.
Okay, Prof. This morning we have discussed a lot of recommendations or implementation to combating AMRs, antimicrobial resistance, and others. So, have you seen any impact of intervention that we discussed implemented in hospitals on the rates of MDROs, hand hygiene practice, and also antibiotic use in our hospitals over the past years? Maybe you can share.
I think before the COVID, we definitely saw a trend in all our MDROs coming down, hand hygiene improving, and antibiotic use also getting better. We under the Ministry of Health, we send all our data to Ministry of Health. Among all the Ministry of Health hospitals, University Hospital, ours was always the worst when it came to MDRO, as well as antibiotic use, especially broad spectrum, and we started getting better. But unfortunately, COVID came, and and this is not a phenomenon only in University Hospital, worldwide, even in Johns Hopkins. And if you open any papers now, you will see that MDROs have gone up throughout the world. Hospital-acquired infections also have gone up throughout the world. Even CLABSI in Johns Hopkins went up. And that's what we saw in our hospital as well. CLABSI is going up as well. I think everyone would think that during the COVID, our PPE, our hand hygiene, our MDRO would have gotten better, but actually it didn't. Unfortunately, as Zuhairah pointed out, just using the PPE is not important. How we use it is also important. So if you wear your PPE to protect yourself, I wear 3 gloves because I'm protecting myself, but you're not protecting your patient. So you have caused the patient to have a CLABSI or a MDRO because you did not change your gloves between patients. And to overcome this bad practice in infection control, you end up overusing your antibiotics. Because I didn't do my hand hygiene, I might have given the patient an infection. So now I'm going to give carbapenem for my patient. And this is how the vicious cycle starts. So I think moving forward, now that COVID is coming down, everyone has gotten vaccinated, I think we have to start looking back at our practices and seeing how we can work better for our patient safety again.
Okay, thank you, Prof. We have a lot of Q&A in the chat box, but unfortunately, because of time constraint, I think we may proceed. Or Prof want to...
Yeah, I thought maybe I could take 1 or 2 questions. I think one of the questions was allergic to penicillin wrongly. Why it happens? Well, I think the penicillin allergy, as you know, sometimes patient comes and says, I took this antibiotic and I started vomiting. All right. And somebody will just put it down as this patient has got penicillin allergy. And then the patient will come and tell another doctor, oh, I've got penicillin allergy. And nobody checks into it again to see whether the patient truly had a penicillin allergy. And that's how the patient gets labeled as penicillin allergy. I one day was referred a patient that from another doctor that said, we want vancomycin for this patient. We want some broad spectrum antibiotic for this patient because the patient's father has got allergy to penicillin. So there's so much of fear now of allergy that they think it's also inherited. So penicillin allergy is not an inherited thing. So sometimes a patient is mislabeled when they were young, maybe, and then the patient comes and says, I'm allergic, and nobody actually kind of checks again to see how true this allergy story is. So I think that's how it happened. I think there's a question on completing. How do we know when we are completing the course and not giving the antibiotics for too long? Well, I think this is based on guidelines. So if we open our IDSA guidelines, and also you can have a look at the UMMC antibiotic guideline. I think we have quite a comprehensive guideline that tells you what is the duration of therapy for most common infections. For example, osteomyelitis, you need probably 6 weeks. How many weeks of IV and how many weeks of oral? Community-acquired pneumonia, how long do you need to treat it for? Bloodstream infection, not all bloodstream infection need 14 days. In fact, now studies have shown for gram-negative bacteremia, even 7 days is enough. And you don't need an IV throughout. Once patient gets better, you have a good bioavailable drug, you can actually change to oral. So I think to know the proper duration, you have to look at the guidelines. But to know the duration of therapy, you need to know your diagnosis. Unfortunately, a lot of doctors write fever, give antibiotics, without saying the patient has got I don't want to say osteomyelitis again. I might get killed by my orthopedic friends. But okay, but just let's say community-acquired pneumonia. No one says pneumonia. Patient says cough and cold and then gives antibiotic. But if you write down this patient has got community-acquired pneumonia clearly, then you'll say, okay, 5 days. If you say this patient has got simple cystitis, 3 days or 5 days. This patient has complicated pyelonephritis, then you can decide on your antibiotics. Unfortunately, we don't write down our diagnosis clearly, and that's why we are unable to decide on the duration of our treatment. So I think from the start, to be good clinicians, we have to first decide what is our diagnosis, and then the rest of it will just follow quite smoothly. Someone has asked about what are we doing about agriculture and things like that. Well, I would like to let you all know that we have a national action plan. This happened, I think, about 5 years ago. It is a One Health solution. We have got the agriculture, we have got animal health body working together. And now actually animal health have started recording the use of certain antibiotics, especially critical antibiotics that are used in humans. Most of it are banned in animals. So there's now more regulation on it. We are still working on that, but at least things are already in place. I think the rest of it, maybe we can type out the answers, Ka Yin, maybe to some of it, and unless there's some burning questions in there. Sazali, is there anything that is burning that we need to
maybe Ka Yin can answer the cost of antibiotics in a hospital, maybe a week cost of meropenem or vancomycin in a hospital. Ka Yin?
Sorry, what's the question again?
Regarding the cost of broad spectrum antibiotic in our hospital, for example, a week of vancomycin, how much it costs, or a week of meropenem, how much it costs compared to.
Oh, all right. So let's say vancomycin is quite an old drug, so it wouldn't cost that much. But the side effect of vancomycin probably will cost the patient's kidney. So that cost can't be calculated because this vancomycin is nephrotoxic. So let's say this patient might be an elderly. To start off with, the kidney function wasn't that well. Then after giving vancomycin, the patient's kidney function went down the hill and required dialysis. So the cost following that would be more than antibiotics, I would say. So let's say if you want to go to the higher end of antibiotics, broad spectrum antibiotics, such as, let's say, this patient has VRE, then requires linezolid or daptomycin, this cost will go up to, I think, at least 6,000 to 8,000 ringgit for the 2-week cost. And sometimes it's not only 2 weeks that the patient will continue on. Probably it will continue on to maybe 3 weeks or 4 weeks, depending on the severity of infection and also how deep-seated is the infection. Let's say there's an abscess. So I would say that the cost to the hospital is quite high to treat an NDRO.
Yes, I agree with Ka Yin. There's direct cost and so indirect cost in treating patients, right? But I think the most important is patient health and also benefits and doing best for the patients. Okay, I think we come to the end. Before we ending our today's forum, then I would like to ask each panelist to give their some final words and also of advice and on how we can increase awareness on judicious use of antibiotic and improve our hand hygiene practice. Maybe we can start with Prof. Sasheela.
All right. Well, I've got this written down, and I thought it's really important. So we have all experienced a pandemic, okay, a devastating pandemic. I think this is, the first time the whole world has seen something as bad as this, where initially there was no treatment, there's no vaccine, and this disease took millions of lives, crippled the healthcare system and also the economy around the world, okay? And now it has changed our lives totally, right? Our lives will probably never be the same again. Now I want you to imagine a pandemic where there's no more antibiotics, right? To treat simple infections, and people are going to die of community-acquired pneumonia. They're going to die of a simple prick of a rose thorn and they get a skin and soft tissue infection, and they're going to die of it because of strep infection, dying of a simple urinary tract infection, puerperal sepsis, or dying of any simple surgery or even chemotherapy. And all this will become life-threatening because we don't have any more antibiotics. I want you to know that multi-drug resistant organism is a slow-growing pandemic. And if we do not take any action today, we will definitely face the consequences. So just think about what COVID has done to us. And imagine now if you had to go to a hospital with a pneumonia and they tell you, I don't have any antibiotics for you. And this is what happened many, many years ago. Orthopedic infections, the treatment was amputation. There was no antibiotics. And we are going towards that direction. For example, we have seen patients with Pseudomonas implant infection, which is pan-drug resistant. There's no antibiotics for that patient anymore. So think about it. If we don't want to go down that route, we have to start being judicious with our antibiotic use and our infection control practices. And I can tell you, if we do that, we will revert the multi-drug resistant to normal, because that's how microorganisms are. Okay? It's all called selection pressure. We are causing the pressure for these organisms to become resistant. Okay? So that's what One Health is all about. We need to learn to live with our organisms, not, we are parasites actually at the end of the day, if you think about it. So that's my parting words.
Okay, thank you, Prof. Maybe Puan Shima, your last words.
Okay, I think to add on, Prof. Sasheela has said that in order for us to have a good culture in our clinical area, the most important thing is the leadership in that area, because role model is very important. So I personally pledge to all the doctors, consultants, lecturers, and even all the nursing sisters who are here today, so that we continue to lead this infection control, so that we can have a good culture of correct prescribing and also infection control practices. So my word is that infection control is doing the right things even without anyone else looking. I think thank you so much.
Okay, next maybe Zuhairah, your few final words.
Thank you, Dr. Sazali. I think as a junior doctor, I would like to encourage my colleague who is, I think, at the starting of our journey in this career to keep searching for the correct knowledge and practicing the right thing so that we can provide the best for our patient, for the safety of patient and also our safety. I think that's all.
Ka Yin?
I would think that doing a correct diagnosis will help in getting the most appropriate antibiotics. We need to use most appropriate antibiotics, the correct dose, and the correct duration. If, let's say, if doesn't know how much to give or how much to give according to patient's renal function, you can look under UMHealth antibiotic guidelines, or if you're still not sure, you can always call the pharmacist. The pharmacists are very happy that we could help you in deciding of the dose patient. Thank you.
Okay, thank you. Ladies and gentlemen, AMR is everyone concerned. So every of us play a vital role in combating emergence of AMR. We should use antibiotic with care and adhere with good infection control practice, especially hand hygiene. So hopefully today's discussion had achieved the objective in raising awareness on antibiotic use and hand hygiene. Second, save life, spread awareness, and stop resistance. Thank you for all of the panelists for your time today and also your sharing. Before that, special request actually from our chairperson and also my colleague, Dr. Ong Han Cheng. I would end our today's forum with 2 rangkap of pantun. Melata pamah cantingan batik, Menyingsing cahaya bersinar megah, harus berhemah guna antibiotik, kuman bahaya dapat dicegah. Kayuh perahu kiambang menyisih, bawa muatan bunga selasih. Cuci tangan sampai bersih. Cukup sekian, terima kasih. See you tomorrow morning at Dataran Siti Khatijah for the launching of Antibiotic Awareness Week and also Hand Hygiene Campaign 2021. Thank you.
Thanks, Sazali. I really miss Malaysia. That's so beautiful to hear Malay. Wonderful pantun. Thank you very much.
Thank you, everyone.
Thank you, everyone.
Thank you.